All modern mechanical ventilators display a pressure waveform. That's pressure versus time. And I'm going to review this at the beginning of this tutorial. But the principal part of this tutorial is looking at pressure volume curves and why they are useful and why you should be looking at them in anesthesiology and critical care. This is part of a series on ventilator waveform analysis, and this particular tutorial is on the pressure waveform and volume pressure loops. You will recall that I like the Puritan Bennett ventilator screen to look like this. On the left hand side we have waveforms, on the right hand side we have loops, and those waveforms are pressure versus time, flow versus time, and volume versus time. The two loops are volume versus pressure and flow versus volume. In the previous tutorial we discussed flow volume loops, and I explained that you need to be very careful when you're looking at this to figure out what way the loop is orientated. Sometimes inspiration is above the x-axis, sometimes below. Sometimes the 0 point is where the x and y-axis intersect, but sometimes it's over on the right-hand side. I showed you the flow volume loops for sinusoidal, constant and decelerating flow patterns, the flow volume loop in bronchospasm and airway obstruction. I showed you how they were slightly different, the flow volume loop when there was a cuff leak and the loop in auto-PEEP. This time we're going to look initially at normal airway pressure waveforms. I'm then going to start discussing dynamic volume pressure loops, and I'm going to show you some abnormal volume pressure loops. At the very end I will mention static volume pressure loops. Let's start with pressure. Gas always moves along a pressure gradient from high pressure to low pressure. Spontaneous ventilation is associated with negative interthoracic pressure. Mechanical ventilators use a piston to drive gas flow into the lungs, and there is a gradual rise in airway pressure as a result. The airway pressure increases directly in proportion to the velocity of flow. The pressure reading reflects flow, airway resistance and parenchymal compliance. Regardless of the velocity of flow, in volume control ventilation, the end inspiratory alveolar pressure is always the same. In pressure control, the velocity of flow is proportional to the pressure ramp or driving pressure. I think it's worthwhile, before we get into the pressure waveform, to quickly look at flow pressure loops. This is not a conventional loop that you will see in an ICU ventilator, but it's on a lot of the modern anesthesia machines. Let's start with the scalars. On the y-axis we have flow, and that can be either positive or negative, and on the x-axis we have pressure, and that can be either positive or negative. Sometimes this is a little bit hard to get your head around. As flow increases, pressure increases simultaneously. So we should see the loop going across and upwards on inspiration, and then when expiration occurs, then the loop will go downwards, reflecting exhalation, negative flow, and to the right for positive pressure breaths. Let's have a look at a breath. What type of breath do you think this is? You can see that when the breath starts, the airway pressure goes below zero, and this continues until the end of inspiration, after which the airway pressure is slightly positive. So this is spontaneous breathing, such as you see under anesthesia. And if you put up the flow pressure loop while you're giving an anesthetic, this is what you see. Sometimes it just looks like a straight diagonal line, and it goes in that direction. Now this is a controlled mechanical ventilation breath. What mode of ventilation or vent strategy do you think I'm using here? Here's the hint. The flat shape of the flow waveform reflects volume control, constant flow ventilation. So flow starts and it just goes constantly until the end of the breath, and then of course it releases and the airway pressure goes downwards. What do you think of this particular loop? In this case, the loop angles upwards gently. It looks like the tail fin of a jet plane, and this is the pattern you see with decelerating flow patterns, either volume control with a decelerating flow pattern or pressure control, which always has a decelerating flow pattern. So keep these flow pressure loops in the back of your head when you're in the operating room. Have a look at the vent screen, see what you think, and later on in the course we will revisit them. But let's move on and have a look at the pressure time waveform. These are our scalars. We have pressure on the y-axis, and again that's either positive or negative. And I have a little grey line there to reflect the PEEP level, which might be, for example, 5 centimeters of water. And then on the x-axis, we have time. And that time is in seconds, and I've drawn 3 seconds. Let's give the patient a couple of breaths. And as you can see, the pressure waveform goes up very rapidly to a peak pressure level. So we start here at PEEP, and we keep going until that peak pressure level. And that's a standard shark's fin, volume control, volume cycle breath. Sometimes you'll see a little divot before the breath, just like this, where the airway pressure is a little bit negative just before the breath starts. And this is the patient triggering the vent, generating negative pressure in the airway, and the ventilator triggers. And this is a volume control, volume cycle breath. And this is what it looks like on the vent screen. Here we have our pressure waveform. Note that shark's fin pressure waveform, and here is our volume waveform. Remember, when you see that green bit on the waveform, that is what the ventilator is doing to the patient. The yellow bits are all passive. The scalars here are time, and this is the magnitude of airway pressure. And of course, in all ventilators, you can blow up that pressure waveform. Pressure waveforms tend to be either sine waved, they can be shark's fin, like I've just shown you, or they can have a top hat or a top hat with a bump feature on it. So the sine wave pattern looks a bit like this, and we visited this before. And this is a patient who's on CPAP, who's breathing spontaneously, and you can see that slight negative deflection on inspiration and slight positive deflection on expiration. And I showed you that you can do this, of course, on bi-level ventilation, where you allow a patient breathe spontaneously so long as pressure support has been switched off. The shark's fin pattern I already mentioned in this tutorial, and it looks like this, where the airway pressure progressively goes up to the peak pressure, and then the ventilator either holds the breath at that level or it releases it on volume cycles, and that's what this breath looks like here. Now there is another version which I call the top hat with feather pattern, where the top of the waveform is really flat. So you have a little bit of a bump, and then it falls down to a lower level. So we have a peak pressure and then a plateau pressure. And that's what you tend to see if you're using volume control ventilation with a pause. And in this case, there's a 0.3 second pause on the square wave pattern. And you can see this lovely flat top after a little bump on the top. I think of this as a top hat with a feather sticking out of it. And that is very, very particular to volume control ventilation that is constant flow. The flat top pattern can be seen in a variety of different modes of ventilation, and it looks like this. The airway pressure goes up progressively up to a pressure limit, and it stops there. The patient can also trigger the ventilator, and the pressure cycles up to this flat top picture. Now, this is not exclusive to pressure control ventilation, although it's very, very typical of pressure control. This is a patient who's on volume assist control ventilation with a decelerating flow pattern on their flow waveform. And let's just zoom in on that waveform, but you can see here, totally flat top picture of their pressure waveform. So you can get this in volume control if you use a decelerating flow pattern. And sometimes it's a little bit confusing if you just roll up and look at the screen on the ventilator. On a patient who's on pressure assist control, it looks like this. Again, decelerating flow waveform, and what distinguishes this from the previous one is there's a little bit of a pause at the end of inward flow, but again, same flat top pattern. One thing that you should understand is that although the airway pressure waveform may be flat topped and square shaped, that is not a direct representation of the increase in alveolar pressure. And that looks like this. Regardless of the shape of the pressure waveform, whether it's square shaped or triangular shaped, associated with decelerating flow or constant flow respectively, the alveolar pressure change is the same, and there is no evidence of improved outcome using decelerating flow versus constant flow. The airway pressure waveform reflects the impact of gas flow on transit airways and subsequently the lung parenchyma. That's the plateau or alveolar pressure. This is principally impacted by airway resistance and parenchymal compliance. For the patient that is not breathing spontaneously, abnormal waveforms generally reflect flow resistance. The other great value of the pressure waveform is that it helps you detect abnormalities of patient-ventilator interaction. And these are asynchronies or dysynchronies. And I prefer to separate out these two terms. Some people just call them all asynchronies, and I don't know if that's correct or not. Asynchrony, in my view, is where the patient is attempting to breathe, but not every breath is detected by the ventilator, or the ventilator is detecting breaths that do not exist. And this is a problem of triggering. Dyssynchrony occurs where there is dysfunctional interaction specifically between the patient and the ventilator. It occurs when flow is too fast, too slow, too long, or too short. And this is a problem of flow control. And I will cover this in detail in a subsequent tutorial. This is a different pressure waveform, and this is what you see with pressure support. You can see that the patient is triggering the breaths. That's why I've colored them red. And the two different breaths that you see here are of different duration, but the pressure support limit is the same. So the pressure support inspiratory pressure is always the same, so that is always the pressure limit, and it looks like this. We can zoom in now and have a quick look at these breaths, and you can see the pressure waveform here. Here's the pressure support inspiratory pressure limit, and you can see that each breath is of different duration because it's flow cycled. So the flow waveform will look very, very different, as does the pressure waveform, but the inspiratory pressure limit is the same. And of course, you can measure all of these points if you freeze the screen and pick out the point where the patient is at end inspiration, as in this picture. And you can freeze the video and have a quick look at this if you like. You may recall this cartoon from the tutorial on flow waveforms and flow volume loops. I pointed out that the failure of the flow waveform to return to baseline in expiration is pathognomonic of auto-PEEP. However, to measure the amount of auto-PEEP, you need to go to the pressure waveform, and what you do is perform an expiratory hold. And you can see that this patient has a PEEP of 5 centimeters of water, and we're going to go and we're going to pause exhalation and see what happens. This is the point of the pause, and you can see that the baseline pressure waveform rises up to 8 centimeters of water. So the total PEEP here is 8 centimeters of water, and that means that the total PEEP minus the PEEP equals the intrinsic PEEP or auto-PEEP, and that's 3 centimeters of water. And this is a really useful maneuver to do on all of your patients every day. Now, let's move on to the main topic of this tutorial, the volume pressure loop. Let's start again with some scalars. This is the volume pressure curve. So pressure in this case is on the x-axis and volume is on the y-axis. Pressure is in centimeters of water and volume is in mils. That volume in this case is the tidal volume because this is the dynamic volume pressure curve, such as you see on your ICU ventilator and your anesthetic machine. Consequently, when pressure increases, volume increases, and the curve will go in this direction. If the lungs are more compliant, the inspiratory portion will look like this. And if the lungs or the total respiratory system compliance falls, the inspiratory curve will look like this. In expiration, the airway pressure falls and the tidal volume falls simultaneously. The expiratory loop goes in this direction. Now let's look at a few normal loops. What do you think is going on here? Well, as you can see, the airway pressure actually goes negative initially in inspiration before arriving back at 0 at end expiration. The airway pressure is then slightly positive in expiration. So this is the normal spontaneous breathing picture. In this situation, we've set a PEEP of 5 centimeters of water. and the patient is breathing spontaneously. And this is what it looks like, that same loop, slightly negative initially, slightly positive subsequently. And this is the picture you see with CPAP, continuous positive airway pressure. Again, here's our PEEP. Let's see what happens in this situation. So what do you think is going on here? Well, the airway pressure is about 20 centimeters of water and the tidal volume is 400. And what's important to see is that airway pressure goes up, bam, 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 stepwise. It's just a straight up diagonal waveform. And this is the picture you see with volume control ventilation with constant flow. That square flow pattern, and the airway pressure goes up progressively. And if you were to see the pressure waveform, it would be the shark's fin that I mentioned earlier on. What do you think is going on here? You can see that the inspiratory pressure goes from the PEEP level of 5 centimeters of water right up to 20 centimeters of water. This is the pressure limit, and it stays there for the duration of the breath, and then the patient goes into exhalation. So this is the picture that you see with pressure control, including dual control modes like volume guaranteed pressure control. In this picture, I'm just going to overlay the volume control and the pressure control waveforms. And you would think that the airway pressure is different in these two different approaches. The alveolar pressure, though, is exactly the same as I mentioned earlier in the tutorial. It just looks different on the volume pressure curve. What about this one? The red inspiratory curve is indicative of spontaneous breathing. It's a pressure control curve because it goes right up to the pressure limit and then it releases. This is the picture that we associate with pressure support ventilation. Now let's have a look at some abnormal volume pressure curves. And I'm going to suggest that you pause the video when I put up these curves just to think about them for a second. So here's the first one. This is a patient who's on pressure control ventilation with a driving pressure or an inspiratory pressure of 15 centimeters of water. That's on a PEEP of 5. So that blue line there is the PEEP. Let's roll the loop. Now pause for a second and see what you think is going on here. What's wrong with this picture? As I mentioned, the patient is getting a PEEP of 5, but the breath is not starting at the level of PEEP. It's actually starting here at about 8 centimeters of water. It not starting at PEEP, but starting at a higher pressure suggests that there is auto-PEEP present in the system. So this is auto-PEEP and what you typically see. This patient is on volume control ventilation with a tidal volume of 450 mils and a PEEP of 5. And you can see here, they get this very, very nice looking volume pressure curve. The compliance is very good. The airway pressure is about 13 centimeters of water. A couple of hours later, you go back to see the patient and it looks like this. The curve looks quite similar, but the plateau pressure has gone up to 17 centimeters of water. Then another couple of hours elapse, and you go back to see the patient. The curve looks similar again, but now the airway pressure is 18 centimeters of water. So what's going on here? What has changed with this particular patient? This is an example of progressive loss of lung or total respiratory system compliance. The rate of change of volume with respect to pressure has altered. It's now taking much more pressure to generate the tidal volume that you require. What may be happening here is that the patient's lungs may be filling with fluid, or they may become consolidated, or the patient may be developing another problem such as intra-abdominal hypertension. What's going on here? The inspiratory curve looks normal. It's the same as you've seen on previous cartoons, but there's something wrong with the expiratory curve. It goes back and it looks a bit jittery and then it kind of rolls downwards. So there's a problem with expiration. And when you see a problem with expiratory flow, you think about increased airway resistance, particularly bronchospasm. What about this picture? In this example, and remember this patient is on volume control ventilation, the initial inspiratory flow is very different from what we've seen before. Instead of going directly upwards, it's kind of rolling outwards, a bit like what you see in pressure control. It goes up to the airway pressure and then really slow to resolve. I'm going to overlay the normal volume pressure curve for this particular patient. There is much higher pressure required in inspiration and much higher volume in expiration. This is an example of airflow resistance in both inspiration and expiration. And there's lots of reasons why this may happen, and I will cover this in the next tutorial. But when you see both inspiratory and expiratory resistance, you have to think of things like foreign bodies in the airway, or a kinked endotracheal tube, or a plug in the airway. Now carefully look at this and see what you think is going on. Your initial response is probably that this looks okay, it looks fairly normal, but it would if this was a volume control breath. But in fact, if you look to the left of the screen, this is pressure control ventilation with an inspiratory pressure of 15 and a PEEP of 5. I'm going to overlay now the normal pressure control volume pressure curve. There is a major problem with flow going in and out of the patient. And this is the picture you see with airflow resistance and pressure control, particularly if there's a kinked or obstructed endotracheal tube. What do you think is going on here? I'm going to show you how this curve should look. Pressure is fighting against flow. The patient is trying to drag flow out of the ventilator. That flow is not being delivered because volume assist is flow limited and the airway pressure is reducing. You can zoom out and this is what it looks like on the main screen. Note the constant flow pattern. The peak flow has been set at only 29 liters per minute. Now let's look at the pressure waveform. The pressure waveform is scooping inwards. This is what the waveform should look like. The treatment for this problem is to increase the peak flow, for example, to 50 liters per minute, or to change the patient over to a pressure-controlled mode. This is the same patient on a Vmax or a peak flow of 50 liters per minute. There's still some scooping going on. Let's go up to 60 liters per minute and see what happens. And still there is some scooping. This patient would be much better off from pressure control. All the curves that I've shown you so far are dynamic curves that can be used to assess dynamic compliance. However, the textbook approach to pressure-volume relationships is to devise a static volume pressure curve in an anesthetized paralyzed patient. The lung is gradually inflated and pressures are measured during incremental volume increases. It is called quasi-static because, of course, air must be continuously absorbed from the alveoli, and the volume applied is not necessarily the static lung volume. The construction of volume pressure curves is the foundation of an approach to mechanical ventilation in ARDS known as the open lung approach. It's based on the idea that there is a measurable inspiratory pressure at which the lungs suddenly open up and recruit, having been matted down. This is a static volume pressure curve for a patient with ARDS. You'll note that the inspiratory part of the curve is relatively flat up to a pressure of about 12 centimeters of water. Then the volume per unit pressure increases rapidly. This lower inflection point on the curve is known as the P flex. And in the open lung approach theory, if you put the PEEP level at or above the P flex, there is optimal lung compliance and minimize phasic inflation and deflation or recruitment and de-recruitment of lung tissue that causes a problem known as atellect trauma. As one progresses upwards, there is a point at the top of the curve where it flattens out. The lung is no longer able to expand well above this point, and it is assumed that any additional pressure applied to the lung at this level causes damage. So this is the upper inflection point of the volume pressure curve, and it's known as the P max. Applying the logic of the P flex and the P max to clinical practice, one would assume that the ideal place for PEEP is just above the P flex, as the lungs do not get the opportunity to phasically de-recruit, and the pressure limit should be set at just below the P max. And this is what the volume pressure curve should look like after that maneuver. While constructing these static volume pressure curves sounds great and it looks cool when you read about it in journals, doing it in practice is quite tricky, and of course very few people actually do this for lots of reasons. 1, you need the equipment. 2, you need the skill. And 3, you need to have nerves of steel, because these are the sickest, most hypoxic patients that you will encounter, and they desaturate very quickly. I do not create static volume pressure curves in my practice. How you can use the same theory, though, using the volume pressure curve or just measurements of compliance, is to do a PEEP decrement trial. I always use pressure control ventilation to do this, and this is an example. I've set the patient on pressure control with an inspiratory pressure of 10 centimeters of water. Now you can use 15 if you want, and I've set the PEEP at 15. I rarely ever use more than 15 of PEEP, so this is where I start. You can use 20 if you like. Let's give the patient a breath. Now what you can see here is that this patient has a tidal volume of 300 mils with a driving pressure of 10 centimeters of water. I will point out that before you do this, you really do need to check that there isn't a lot of auto-PEEP present. That 300 mils per 10 centimeters of water gives you a compliance of 30 mils per centimeter of water, which is okay, but it's not spectacular. Now normally you'll drop down the PEEP level in 1 to 2 centimeters of water increments, but just for teaching purposes, let's drop it down to 10 centimeters of water. Now let's see what happens. In this situation, the curve is so much more upright than it was in the previous picture, and the tidal volume is 500 mils for the same inspiratory pressure. As a consequence, we are now measuring a compliance of 50 mils per centimeter of water. So that is a significantly better picture. And the reason why the compliance is better for the same driving pressure is because the PEEP is pushing that patient with 15 centimeters of water of PEEP above the P max on the volume pressure curve. So coming down to 10, we are now certainly between the P flex and the P max. Now let's drop the PEEP down to 5. Let's see what happens. Wow, in this situation, you can see that the tidal volume is only 400 mils, and that results in a compliance of 40 mils per centimeter of water. So that is not as good as it was at 10 centimeters of water of PEEP. So we can be very sure now that the PEEP level that we've given this patient is below the P flex. So the optimal PEEP is higher than this. Now it might be 7.5 centimeters of water, it may be 12.5 centimeters of water, but this is how you do a PEEP decrement trial. And I find it very useful, and this is what I do to set best PEEP for patients. The other things you need to take into account, of course, is your oxygenation, which may deteriorate with the lower level of PEEP, and your ventilation, which may be very poor at higher levels of PEEP. Now, there is a way of measuring static lung compliance, and it's on every mechanical ventilator if you look carefully. On your ventilator, there's a button on the bottom of the screen that if you push it, up pops a window that generates an inspiratory pause, and that pause will give you a static lung compliance. To explain what's going on here, you need to understand that when an inspiratory pause maneuver happens, both the inspiratory valves and the expiratory valves close, and there is zero flow in the system, so everything just equalizes out. And because this is being applied at end inspiration, you get a proper plateau pressure. And what is displayed on the screen here is that plateau pressure, where it drops a little bit from where you would expect. The machine then calculates out a static lung compliance that may be slightly different from the dynamic compliance. In this particular case, there's quite a difference, and it gives you a plateau pressure, a measured plateau pressure that you can record and compare later for the patient. Moving on to another patient, and this patient has severe hypoxic respiratory failure, usually called ARDS, acute respiratory distress syndrome. The patient has very poor lung compliance, as you can see from the dynamic compliance of 16 and the very, very non-compliant volume pressure curve. But what I want you to focus on is the pressure waveform. And if you look at the pressure waveform, it appears that the peak and the plateau pressure are more or less the same, just north of 30 centimeters of water. And I've pointed out throughout this course that intensivists find that number very uncomfortable, because we believe that above 30 centimeters of water of distending pressure, the lungs become damaged. However, you really do need to check an inspiratory pressure on this particular patient. So let's do an inspiratory pause and see what happens. And here is our peak pressure, but see what happens when the inspiratory pause is applied. The pressure falls right down to a lower level, and that's the true plateau pressure, which in this case is 25 centimeters of water, and the compliance statically is the same as the dynamic compliance. Let's review this tutorial. This was a tutorial about pressure waveform analysis. We started with a discussion about flow pressure waveforms, and then moved on to talk about pressure time waveforms. These are the pressure waveforms that you see on all mechanical ventilators. I subsequently showed you how to measure auto-PEEP on the pressure waveform. We then moved on to talk about volume pressure loops. Often people refer to these as pressure volume loops interchangeably. It doesn't matter what way you describe it. It is only ever described one way on the ventilator. That's volume on the y-axis, pressure on the x-axis. And I showed you normal volume pressure loops and abnormal loops. We then discussed quasi-static volume pressure loops that you will read about in the journals, but you are unlikely to ever perform in clinical practice. Finally, I discussed the inspiratory pause maneuver to actually measure static compliance and true plateau pressure from the pressure waveform. Next time, I will discuss the patient with high airway pressures, working the problem of high airway pressures, evaluating high airway resistance, and briefly, I will mention how to manage bronchospasm. I'll see you then, and I guarantee you'll learn something. So that was pressure volume curves. If you found this tutorial useful, don't forget to subscribe on my YouTube channel at CCM Tutorials, or where I blog at ccmtutorials.org. Yeah.